chosen one topic which is very relevant to many of our patients. The topic is the heart valves go to the heart. There are four heart valves inside the chambers. As you know, there are four chambers in the heart. There are four heart valves: the aortic valve, the mitral valve, tricuspid valve, pulmonary valve. What do these valves do? They are like gates. These doors open in one way. They don't open in a back way. The blood flows from one chamber to the other chamber in one direction. So this is a one-way valve. These are all made up of fine membrane-like structures. It allows the blood from one chamber to the other chamber, but not vice versa. The blood cannot flow from left ventricle to the left atrium. The same way, right ventricle blood cannot flow from right ventricle to the right atrium. So there is a pathway of blood. The venous blood will go to the right atrium from SVC, IVC, from right atrium to the right ventricle. The oxygenated blood from left atrium will go to the left ventricle and goes to the aorta, to the aortic valve. So there are valves to follow this flow of blood. This is the basic anatomy one should remember. There are two important valves which we are all worried: mitral valve and aortic valve, left-sided valves. They control the left-sided flow. So they make a lot of difference if they are diseased. Now, there is something called rheumatic heart disease. It's a disease where youngsters in their teens, they get infected with one simple bacteria, streptococcal bacteria. It initially affects the throat. They'll have some sore throat kind of infection. Then slowly it involves the joints. Then it licks the heart valves. Although it begins in the joints, at the end it starts destroying the tissues of the heart valves, especially the mitral valve and aortic valve. This is the most common pathology in our population, in Indian setup, where we see a lot of rheumatic heart disease. Some of them developing into heart valve disease, requiring one or the other intervention to them. How does they come out? What are the symptoms? Usually they represent like breathing issues. The heart valves, once it's diseased, it can cause either stenosis. Stenosis means the blood flow, the area of blood flow comes down. The area comes down and the obstruction starts. The blood cannot flow through it. It is called stenosis. Either it's mitral stenosis or aortic stenosis. The second is regurgitation. It is nothing but leakage. Leakage means the blood flows backwards from left ventricle to left atrium, something like this. From left ventricle, from aorta to left ventricle, backwards. So this is regurgitation. Either it can be mitral stenosis or mitral regurgitation, or some of them will have both components, both stenosis and regurgitation. They will have varying symptoms like breathing issues. They cannot breathe easily when they travel much distance, like 100 meters. They can't breathe easily. They'll have breathing issues, breathlessness. Second thing, they can't walk up hills. They can't climb stairs. One floor, they will get breathless. So that is where you need to consult. They may have cardiac other symptoms like chest pain, palpitation. So, or they may be asymptomatic totally. Found out during one of any of the recent investigations, 2D echocardiogram. So once we diagnose, how do we diagnose? We diagnose by doing a 2D echocardiogram. Simple test, simple scanning of the heart, which will allow us to see the heart pathology, heart structures, the valve structures, and assess the severity. And we can grade the pathology into three parts: mild, moderate, severe. If it is mild, they may not have any symptoms. Most of the time, no treatment required. Moderate, yes, follow up is required every 6 months. Some medication to control. And severe, definitely patient needs some treatment. Severe, symptomatic, they have to go for an intervention or surgery. Most of the time, once it becomes a pathologically blocked valve, definitely they will be candidate for surgery. So these doors to the heart, once they give trouble, the blood cannot enter to the next chamber. So the patient will suffer. Once we diagnose, we make them understand that patient requires a surgery. What type of surgery? Valve replacement surgery. Most of the times, the replacement or repair. Sometimes, if it is a mitral valve pathology, and if the valve is repairable without any much calcification, the valve is pliable, thin, it can be retied. There is no need to replace the whole valve and put an artificial valve. As a surgeon, our first priority to the patient is to give their own valve without replacing. In case if it is not at all repairable, then we go for the replacement. Then we discuss the choice of valve. There are two kinds of valves: metal and tissue. Metal is a mechanical valve. Tissue valve is a biological valve made up of a biological tissue like cow's pericardium. We have cow, pigs. These are all much identical to our human structure, where we take out the pericardium. Pericardium is a membrane covering the heart. So we take out the delicate membrane out of the cow's heart, and we structurally synthesize and prepare a heart valve. Most of the heart valves are prepared in Western countries. It's a fine structure where it acts like a normal heart valve, where it allows the blood to flow from one chamber to the other, but not reverse. So that's a tissue valve. Metal valve is made of metal. Both have got advantages and disadvantages. But clear cut 60 age we see. 60 age above tissue valve. 60 age below mechanical valve. Mechanical valve, if you put at young age, it will last for a long time. Sometimes 25, 30 years you have seen. So the life of a mechanical valve is long. But tissue valve life is less. Around 10 to 15 years, they say, the breast tissue valve. The problem with tissue valve is it's costly. Costlier, almost double the size cost than the metal valve. Metal valve is a little bit cheaper compared to the tissue valve. But main disadvantage of mechanical valve is you have to take a medication for lifelong. What is that medication? It's a blood thinning tablet. Because it's a metal valve, there is an artificial surface, so blood can get clotted inside when it flows. So we need to address that clotting. How to address that clotting? You give anti-clotting, anticoagulation, antiplatelet. So give some tablet, blood thinning tablet, where it will take care of clotting over the artificial surface. The tissue valve doesn't have that much problem. 3 to 6 months you give this anticoagulation, then stop it completely. See, what happens is this anticoagulation which we give, the tablet acetylchrome or warfarin, it's a common brand names. It needs to be changed frequently. The dosage needs to be changed frequently. One person, one dosage cannot be fixed lifelong. The body is so changing dynamic that the dosage today for this week, 1 mg is enough for that patient. For the same patient, next week or next month, that 1 mg will not be enough. We need to do PTINR blood test and assess the PTINR status. That will tell us how much blood is thin and thick. Depending on that, we need to give the dosage of tablet acetone. We need to keep changing. So some patients feel that doing repeated blood testing is a problem. Nowadays we have kits which we can use at home. It's a simple kit. Prick and put the blood inside the kit. It will give you the INR report. Quickly you can change. Telephone, change the dosage. For tissue valve, that is not a problem. Tissue valve performance is good. Hemodynamics fantastic compared to the metal valve. And even if it gives trouble, it will give slowly. But problem with metal valve, two problems. Thromboembolism. Thromboembolism is clot formation going to the brain, causing paralysis. That's one major problem. Second problem, bleeding. How does the bleeding happen? Bleeding happens because of our tablet, which we use, tablet acetone. Tablet acetone, if it increases the INR more than 5, 10, then it's life-threatening. It can cause bleeding into the brain. Bleeding into the brain can cause paralysis. Half of the body gets paralyzed. So, if the indication is for tissue valve, then go for tissue valve. There is one more indication is pregnancy. If the person, if the lady wants to have a pregnancy soon, tissue valve is because during that time, no need of this acetone business. Free of acetone. Acetone will cause problems to the fetus. So you are avoiding acetone totally. So you can manage the heart valve and the pregnancy both together. So that's one indication. Another indication, patient is in remote place where he cannot monitor PTA, some remote village. Then yes, tissue valve is preferred. But as much as possible, young people, we avoid tissue valve because the chance of calcification is very high. And very soon, within 2-3 years, they'll come back with calcification of the heart, the tissue valve, and we have to replace the first valve and do the redo operation. So this is regarding the valves, tissue valve and mechanical valve. Choose a proper way. Discuss with the patient. Take patient's wishes also into consideration. Then go ahead with the surgery. Surgery is valve repair or replacement. The method is almost same. We cut open the chest. It's called midline sternum. This is conventional. There are many other methods of approaching to the transaxillary or through the side of the chest. I'm talking about the conventional method. Conventionally, you open the chest, then you see the heart, then you connect the heart and the whole body to a bypass patient. It's called cardiopulmonary bypass patient. It's a specialized machine where what does it do? It takes all the blood from the patient's heart and body, circulates, gives oxygen, and pumps back to the patient. During that time, we can stop the heart and lungs. The heart will be stopped, lungs will be stopped, and it is totally disconnected from the body. It is isolated from, not disconnected, isolated from the body. During that time, heart lung machine will take care of your heart and lung function. You arrest the heart, you cut open the heart, you see the heart valve, decide on table, although you have the echo report with you, decide what to do, repair or replacement. Bad valve, calcified valve, replace it. Repairable valve, repair it. You take out all the tissue in replacement, all the tissue, and take stitches, put a new valve, artificial valve, and remove you stick the whatever cut heart tissues and revert back, come back. Then heart will start beating. Surgery takes about say 5 to 6 hours, including anesthesia. Will be done under usually general anesthesia, although we have done some patients with awake also. Means patient will be awake during surgery. They will be talking to us during surgery using the special thoracic epidural anesthesia. That's one of the ways of doing handling it. So once surgery is over, patient will be on ventilator for some time because of general anesthesia. Once patient is out of anesthesia, we take the ventilator, then patient will be able to talk to us and converse with us. Patient will be kept in ICU for 2 to 3 days and we observe the parameters like patient's rhythm, heart rate rhythm, because rhythm changes are very common during while patients surgery. Then we look for other parameters, kidney functions, your brain function, because some people will have clot along with the bar disease, clot inside the heart. Although we take care of the clot, sometimes a small bit of grams of clot can go to the brain and cause paralysis stroke. So we observe all these parameters during the post-operative period in the ICU. Then we shift the patient to the ward. Once the patient goes back to the ward, we encourage them to walk every day and climb stairs. Usually third onwards we start climbing the stairs. Climbing stairs make them comfortable, confident. And fifth day, they'll be fit to go home. Most of the patients with ulcers, they're fit on fourth or fifth day to go home. The only thing is we need to adjust the tablet acetone dosage according to the daily PTINR report. Once the PTINR is stabilized, once the acetone dosage is fixed, then they are free to go. And we'll monitor the PTINR once in a while and fix the exact dosage. Basically, once the heart valve surgery is over, whatever symptoms they had, usually the symptoms will disappear completely. But whatever breathing issues, palpitations, chest pain, all these issues, they will all disappear. Then the quality of life improves a lot. The quantity of life definitely has increased. See, if the patient's valve is severely blocked, the life expectancy is about 6 months without doing any operation or intervention. But if you take care of with a surgery, definitely the life expectancy increases so much. That's the quantity. Then the quality of life. The heart is a major organ. Tirelessly beats for you. And that is damaged. Now that it's been repaired, it will work better in fashion. So you will have more energy to do it. So your quality of life improves. That's the beauty of any heart bypass operation. And once in a while, they have to come to the cardiologist and cardiac surgeon and get the test done and follow up with PTINR and regular 2D echo tests. I will have prepared some of the notes just to make sure that I should not miss anything. So whenever you have a heart problem, valve problem, no need to worry. We are there to help you and it can be easily solved. The risk is about 5% according to the world statistics. The world statistics says 5% risk of any major heart valve surgery. But in our unit, our risk is too less than what the world statistics say. So with very minimal risk, you can undergo surgery. I always tell you should assess the risk, present risk, and the surgical risk. The present risk without any heart operation with your heart disease is much, much higher, 50, 60%. Within 6 months, patient can die. But the surgical risk is just 5%. Compared to 50%, where is 5%? So if you weigh these risks and benefits, benefit of heart valve surgery is about 95%. So you have to go with the benefit. The risk is too much, then avoid. The risk is less, go for the surgery. Then post-operatively, there's one thing which, funny thing which I want to tell. Patients complain, if it's a metal valve, patient come and complain. Whenever they sleep and all, they get some tut 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 weird sound coming from the heart. Although we tell, sometimes they forget and they'll come and complain. Some rare sound is coming from the heart, and we tell it's a good sign. Be happy about that sound. If it doesn't come, then be unhappy and come to us. If it is working naturally, it will make a sound. That sound will be heard, especially when you are going to the bed. When the outside environment is silent, then you may hear the tut 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 sound, metallic sound. That is good. It is very good. Only in case of metal valve, not in tissue valve. So if it is loud, be happy. Don't come to come to cardiologist. If it is not making sound or if it is buffling, then come to us. See, even if the patient gets a valve, new valve, artificial valve, and if even after some years, say 20 years, 15 years, who knows what will happen after 20 years? Now, at present rate of progress in the medical field, we don't know what is going to happen in genetic field and the valves, what type of valves will progress in next 1 year, 2 years, 5 years, 10 years, 20 years. By the time your valve fails, some new other technology would have come and would be very easy to address the new issue. So at present, what is your problem? Address that. Then get out of the situation. Get out of the crisis. Surgery can be done at any age group. I done at 8 years also. 8 years you cannot replace. You can repair the valve. Try hard to repair the valve. 8 years onwards, I've done up to 75, 80 years also. But don't ignore the symptoms. Because if you ignore the symptoms, you'll go to heart failure. You cannot, heart failure, doing heart operation is very, very risky. Don't go into the stage of heart failure where heart is so big, I can't touch the heart and make you suffer post-operatively. Come early, and once it is severe, don't think about anything. Come, we'll diagnose, then do the surgery. And one more thing is talk to other patients who have undergone the surgery. That helps you and gives you a lot of confidence. Those who already undergone, they'll be so happy. They'll be so happy. See, what is the worry of any heart operation? Pain. Pain is the number one worry of any patient. Second is they'll think I may die during surgery. Now, with this advance in the medical field, the risk is so less than 5% risk of death. So it is so beautiful that you just come, get operated, go home safely and live long. It has become so simple. Why do you want to worry about it? That's one. The risk of death is so low. Pain with modern anesthetic technique, the pain is almost zero. Almost zero. Minimal pain. Even if you ask the patient soon after the surgery, very next day you ask the patient, I ask for so many people, they tell, no, I don't have any pain. Amazing. You have cut this bone, you made a major cut, bone is cut, like a fracture. Patient says no pain. Amazing, right? So that's the beauty of our medication, anesthetic medication, painkillers. Most of our patients, they don't complain. Some people are very sensitive for pain. They may complain, but most of patients, they don't complain. So overall, it's a very safe surgery. It can be offered to most of the patients, irrespective of their age. And one should not hesitate to undergo heart valve operation. So there are two other valves also like tricuspid and one more valve, pulmonary. So they can also get problem. So they also can be addressed accordingly. So don't hesitate for a heart valve surgery. We are there to help you. And with this note, I want to conclude today's topic. And once again, wish you all a very happy World Heart Day. Thank you so much. Now I'll ask the viewers for any questions, any doubts, pertaining to our subject, so that we can rectify each and everything. We got some time now. This was the line was supposed to happen at 3 o'clock, 3 to 4 o'clock, but there was an emergency which came, bypass surgery, so which I had to do now. So we are preparing the patient to get shifted to the operation theatre. So I asked my IT team to brief on the surgery, so there was some inconvenience to the viewers. Sorry for that. And whoever have attended, thank you so much. And you can ask any of your doubts to me so that we can answer. Thank you.